Welcome to another episode of the NEI podcast. I'm Dr. Sabrina Siegel, live at the NEI Congress 2019. It's day 5 and we are here with Dr. Hu for an extended Q&A session. Let's listen in as she addresses your unanswered questions from today's presentation.
Hi everyone. In today's session, I covered assessment and management of agitation, and we had several questions that I wasn't able to ask right at the time. So I really appreciate having the podcast to be able to ask these questions, and some people were able to come up afterwards to say hello and ask questions, but a lot of people had to leave and head to the airport. So this is nice, and you can also listen to it at your leisure at another time. One of the questions was about the best practice. It says, please address best practice recommendations for physical layout of the office as well as security protocols to minimize risk of assault in the outpatient setting. And there's a related question, probably from someone else, but very similar, where it said, our CMHC has declined to offer any practical de-escalation other than verbal de-escalation. As providers, we feel that while verbal de-escalation is preferred, that having training beyond verbal de-escalation is needed to prevent injury to staff and patients should an incident occur. Do you feel that having only verbal de-escalation training is sufficient for outpatient psychiatry? So the answer to that is no. I think there needs to be a lot of different methods. A lot of what the talk was today was that there's not just one factor in acute agitation and assaultive behavior and violence. And so starting with the first question that I read off about best practice recommendations for decreasing assault risk in the outpatient setting, having a setting where people aren't isolated. So it's helpful for privacy for there to not be a lot of noise, but one of the better ways to do it is to have sort of a noise canceling speaker outside of the office, but that so that what people are saying, they have privacy, but so that if there starts to be yelling or throwing things, that people nearby can come running. So a group practice setting is going to be safer than a completely private setting. Having the ability to get help from someone in a neighboring office as soon as possible, or from a receptionist, administrative person, those are very helpful. In a large or small outpatient clinic setting, it's good to have more than one exit if possible. So someone being kind of trapped in place is a very dangerous situation. If possible, having a alarm bell of some kind. I recommend having this under the desk or somewhere where you can get to it when the patient starts to get agitated, and it alerts your colleagues, or if you're in a larger setting, it alerts the security people to come quickly. I have a funny story that when I first moved into a new office, when I joined the faculty, I had inherited the office of an older analyst, and there was a safety alarm in every room, which is good, but his was behind the file cabinet. And so when a patient started getting agitated, it looked as though I was going to have to pretend to be dusting back there in order to reach I would have to snake my arm all the way behind the file cabinet. So that's not ideal. So you want to have something where you can, push the button and alert them. And there's also some systems that have like a safety pen, something that is in your pocket or wearable, so that if you're in a situation that's scary, you can alert someone right away. 2 exits whenever it's possible. I wish more settings had 2 exits. There doesn't really seem to be a downside. It's just something that they have to think of when they're making it, but it doesn't seem like it's that high tech or that high cost. When you're designing your office, having the desk where you could get to the exit if you need to, and something where the desk is away from the patient. If the desk is between you and the patient, it not only means that you can continue to keep eye contact on the patient as you're documenting, because so many of our settings now require us to do electronic health records, but if you have your back to the patient when you're documenting, it's not only disrespectful for the patient, but I think it's a safety risk. And then some of the things that I talked about, making sure that you don't have a lot of heavy, throwable objects, bludgeonable objects, sharp objects, where people can reach them. If your furniture is comfortable, soft, it's also a nicer situation for you and the patient, as well as being safer. The question about things other than verbal de-escalation, I think it is very helpful to go through different contingencies for how staff will react if someone starts to escalate. The whole lecture was about pharmacologic de-escalation, and obviously you start with verbal de-escalation, but I think it would be a mistake to assume that all verbal de-escalation is always going to work. I wish we were that effective, but we're not. We're human, and the illnesses that we treat often, they're not super easy. They're very challenging. So verbal de-escalation is important. It's probably helpful to have a code word. So if you don't have the buttons installed yet, if you have something where you can tell a colleague, it should be something that the patient won't automatically know is a code word. So if your code phrase is the umbrella is on the dissecting table, that's not a good code word. If you have, 7 doctors in your office and no one is named something or other, you can pick that. So, if you say Dr. White, if you have a Dr. White, then you don't want to use that as your code word, but so you can say, so the patient is demanding an opiate prescription, and then you can, call on speakerphone. It's like, hi, this is Dr. So-and-so. Can I get the prescription pads from Dr. White? And then, and then in terms of how to handle a situation as it's getting out of hand physically, the first thing to do is to try to get to safety yourself and other people. So I think one of the people who came up afterwards said that their administrators had said to throw their laptop at the patient, and that is not recommended. Hurting the patient as the first thing to do is not recommended, right? So, and that's actually probably not going to be safe for you either. Throwing an object that is just going to make the patient more angry and that they can then bludgeon you with, that's not recommended. So, I would definitely work with your administrators on things that will keep you safe, the other patient safe, and the patient who's becoming agitated. Another question was, I've seen clinical evidence that men with low testosterone levels are more prone to aggression than men with normal levels. Any thoughts as to why? It's actually the opposite. A lot of people with higher testosterone levels will become aggressive more quickly. And I don't do this very often, but I have used anti-testosterone antagonists, things such as Lupron, hydroxy, Megace, I'm blanking on the name. So Megace is the trade name, but for patients where some of the aggression is related to sexual reasons, then having a testosterone antagonist might be worth considering. This is, of course, very controversial. This is not going to be your first choice for almost any patient, but in 20 years on the inpatient unit, I did use it once, and it was very effective. And the patient who previously had been like a powder keg would hurt his parents to the point that they thought he was going to kill them, and he would actually bite himself. He had very low frustration tolerance, and had the sexual desires of a young man his age, but complete inability to cope or socially do that. What's socially cope? What's interesting is that the testosterone antagonists, the side effects are basically the side effects of being less male. Their voices won't change if they've already reached adulthood because the voice box is already there. They are going to be at a higher risk of weight gain, like women, like lower muscle mass and so forth. But they're actually at less risk of heart disease and so forth. So last I checked, the patient that we started on testosterone antagonists in the hospital was living in the community, had not assaulted his parents or anyone else. They were almost going to have to move because he lived near a school, and his aggression had gotten out of control. He's actually a very nice young man, and so his assaultiveness, if not treated, would have had awful repercussions for him and other people. And so in his particular case, that was the best treatment and worked well for him. But as I said, clearly not for everyone. There's a very good question here. It says, it seems as if attributing agitation to dopamine and not glutamate might be incorrect. And it mentions medications like Depakote, Tegretol, Trileptal decreasing glutamate, which is true. I think one of the purposes of the talk was to talk about how many factors there are involved in acute agitation and assaultive behavior, or more than acute agitation. This same question goes on to say Clozaril blocks the serotonin 2A receptor. This is true. And it has very little dopamine blockade. It does have less dopamine blockade than the typical antipsychotics, and it's part of the things that differentiates the typical from the atypical ones is the serotonin 2A blockade. So it's part of what defines and is part of what the efficacy is. And yet all of them still do have some dopamine blockade. So dopamine blockade is probably important for aggression or agitation from psychotic reasons. Glutamate, very important. The medications that this questioner asked, Depakote, Tegretol, Trileptal, these we didn't cover in today's lecture because they're for more ongoing causes of agitation. So certainly these aren't things that right when the patient is throwing chairs and screaming that would be that helpful. But all of these are very helpful in the longer term, less acutely, and Depakote, I think, in particular. There's a question, why avoid sedation acutely when sleep may be therapeutic? I found nothing better than Thorazine in severe acute manic agitation. I think what I was talking about wasn't sedation in terms of sleep and somnolence, but sedation in terms of respiratory depression and so forth. We do like for the patient to be calm, but maybe not unconscious, because this does help us assess the patient. In the emergency room setting, if we have the patient go from throwing chairs to unconscious, then we don't get to ask what's really happening with the patient. And having them calm but able to talk, we may find that there are substances on board that we didn't know about. We may be able to get them either admitted or out of the emergency room faster if we know what's actually happening. So sedation not so much as preventing them from sleeping, but sedation as being able to be calm and be still rousable, still awake. And severe acute manic agitation, yes, sometimes you will have to have them be all the way asleep. But we'll try to have a number of different potential strategies. There's an interesting question that I may not be able to answer correctly, but it does lead to some other interesting things. The person says, I'm treating a 29-year-old Down syndrome patient that has developed agitation. Is there any different considerations in this population we should consider for medications? It's important to remember that with Down syndrome, they are at a higher risk for Alzheimer's type dementia, even at a younger age. And so 29 is, of course, young for anyone without Down syndrome to develop Alzheimer's type dementia, but we've definitely seen people developing Alzheimer's type symptoms with Down syndrome in the 40s definitely, and sometimes even the 30s. So 29 might be right on the cusp. So I don't have a specific, magic, I don't have like something specific for you, but do consider that agitation in someone who previously wasn't agitated, so they've had Down syndrome all their life, but now they're becoming more agitated. It doesn't mention whether the patient is male or female, but the earlier person that I mentioned that benefited from testosterone antagonism was a young male with severe autism spectrum disorder. So some of the people with different developmental delays don't respond very well to benzodiazepines. The acute agitation and developmental delay, the ones that have, I think, FDA approval are aripiprazole has FDA approval for this, and I believe also risperidone. I'm not a child and adolescent psychiatrist, but that's my impression. Might have to update that. And then there's a few very specific syndromes that do very, very badly with benzodiazepines. So Angelman syndrome and I'm blanking on the it's another one of these GABA receptor. It's a genetic thing. I'm going to remember it after I finish doing this podcast. But it's related to Angelman. Angelman is also called happy puppet syndrome. This is the one where they have a very high-pitched nasal voice. They eat everything in sight. They're strangely good at word search puzzles. So they have overall low IQ, but they have particular areas of I'm blanking on the. I saw a very impressive patient where she did do better with low dose antipsychotics, but with benzodiazepines did much worse. So Angelman and the other GABA receptor genetic anomaly, you want to avoid benzos with them. I have another question asking, how about Safras for acute agitation if you can get the patient to take it? So we were talking about the very acute agitation that requires IM, but there's a slightly less acute agitation that does very well with oral medications, and we went over that a little bit, but I didn't mention Safras, and actually that's a very good thought. Safras is absorbed between the cheek and gum in the buccal mucosa, so it is very rapidly absorbed. It doesn't have to get into the GI tract, and as a matter of fact, it's very poorly absorbed in the GI tract. So the funny thing about Safras is if you swallow it, it's actually like cheeking it. So the patient could, we do the Zydis and the Abilify disc melt and the Risperdal M-Tab to avoid cheeking. Whereas for Safras, if they cheek it, it's more effective, and if they swallow it, it's less effective. So if the patient figured that out, that would be a problem. But if the patient is willing to let it absorb through the cheek and gum, it would actually probably take effect faster than some of the other antipsychotics. There's a question saying, what are the inhaler medications? So at this point, the only inhaled antipsychotic is called Adasuve is the trade name, and it's inhaled loxapine. Loxapine is an older antipsychotic, but interestingly has sort of less D2 blockade and more serotonin 2A than most of the older antipsychotics. So in some ways, it's a sort of an atypical typical. And I would like to be able to use it when we get approval at my hospital, at Stanford Hospital. It won't be available for private practices and so forth. It does need to have crash cart available in case someone goes into bronchospasm, but very good, I think, for the emergency room setting and hospital settings, and that's the only inhaled medication right now that's available as an antipsychotic. Could you please give this talk to a few internal medicine family conferences? Thank you. I would love to. Thank you. This is an interesting and controversial question, but I'll do my best. The question is, can you speak to what we can do as a group of providers to help dispel the myths that the majority of shootings in America are directly related to a mental illness like bipolar or schizophrenia? The public is being misinformed by the major news sources. Yes, I agree, and it causes so many problems. First of all, it's inaccurate, and second of all, it's very unfair to people who have schizophrenia and bipolar disorder. It's always seemed very tragic to me that if you had a fill in the blank for most people outside of the mental health setting and said, first word is psychotic. What's the second word? And most people would say killer. They wouldn't say psychotic depression. They wouldn't say psychotic symptoms and so forth. So there are particular risks for people with schizophrenia and bipolar that are treatable. And so in that sense, part of the reason we did this talk is to be able to do something about that. But there are so many violent acts that are perpetrated by people who do it because they are upset and angry about something, because they feel like other people don't deserve the same rights as they do. So a lot of deaths and violence in the United States and worldwide are perpetrated by someone who thought that this was the right thing to do, hasn't lost touch with reality, but has a reality that is supported by their friends and so forth. There's this is controversial, but let's not forget that a lot of the most scary genocides in history were perpetrated by people who had a lot of support behind them. So I would say that we as mental health providers need to help and treat our patients with conditions where they've become predisposed to violence. We need to help prevent violence, and then we also need to work with the media and people in general that it's unfair to label everyone with a psychiatric diagnosis as being prone to violence. I think we could do so much to help our patients. We will be asked from time to time to comment on something having happened, and HIPAA basically says that we shouldn't talk about patients in any way that's identifiable out there. And then there's also the Goldwater rule from the APA that we shouldn't be commenting on someone that we have examined. But I think that we can talk rather than about specific people or specific patients when we're asked by media about, is this the work of a madman? Is one way that the question will be phrased. And you can try to dispel these myths as best as possible.
This wraps up our extended Q&A sessions from NEI Congress 2019. Look for the full recorded encore presentations at NEIglobal.com.